in this type of disease for the next few years. As a conclusion of these two perfectly integrated interventions, we have the last one from this first session from Professor Laura Mazzanti from the Pediatric Endocrinology Unit of the Sant'Orsola Hospital. Professor Mazzanti works at the Bologna University, and she's been following for years, like her previous two colleagues. She follows a large study case of many patients, and she is going to talk to us about a very important topic for the rare diseases, namely transition from pediatric age of chronic patients that have been seen from their first moments of life in a certain ward. At a certain time, they overcome their pediatric age and they have to be transitioned to young adulthood. And this is a problem that is being analyzed for various conditions, and Professor Mazzanti will talk to us about this. Okay, thank you, Professor, for your introduction. I would like to thank the President who invited me, and I am a little bit moved in this Latin University hall. I had never been before. I would like to thank the families, because our experience and our ability to follow them depends greatly on the interaction with them. Today's topic is a rather complex one for me, because when we talk about transition, we also talk a lot about it in the endocrinology group or in the chronic disease field, but we haven't found the right way yet. And it is certainly a difficult time, the transition from pediatric age to be followed in a young adulthood center, and this can be done with a certain serenity if we have a guided pathway to follow. At least in our region, we are trying to see a collaboration between pediatric centers and adult centers to communicate for certain diseases. And this is a work for patients with chronic diseases, Williams disease, and other diseases. What does it take to have a good transition? Should there be dedicated areas or a case manager to act as a coordinator? And it also takes doctors who speak to one another. So the pediatricians and adult doctors should meet and talk. It's not an immediate passage. Their meetings have to be convened, and the issues of these patients must be explained so that there can be a collaboration by the patients' associations themselves. We are already doing this also for other conditions. At the moment, we haven't found adult groups yet that want to be that dedicated. We should consider, especially the most evident issues in this passage from pediatric age to adulthood, and the issues we should focus more on, involving more the specialists that may collaborate with us, especially with reference to the cardiovascular and endocrine system and also the gastrointestinal system. Many of the things that I am saying have been said very well by my colleagues. I'll just take stock of the situation with reference to the issues we should focus more on in these at this age for the patients. These children are more followed than the general population in pediatric environments, so there are they have a larger number of clinical evaluation and multi-specialist evaluations. And with age, some of these diseases have a greater impact. So we should take this into consideration, because all for the services with dedicated to young adults with chronic disease are rare. So that's why our children remain in the pediatric settings, but have adult doctors as a point of reference. So what is the recommended age at transition? It depends on the developmental age and the maturity of the children. Our emergency wards have reached 18 years old, and then you have to go to an adult emergency ward. Like the previous speaker was saying, we have to participate in this pathway, because there is often a difficulty in communicating one's disease, and there is a limited capability by the person who has to be helped very often. And we often see that the doctors that deal with adult patients, as they see this good communication on the part of the patients, they overestimate these abilities, and this could put them into a greater anxiety situation, and they provide less support. And adult doctors should interface more with the pediatric ones who did this, had this pathway, but it's not that easy. For example, in terms of the reservations, in terms of checkups, they have long waiting lists, and the centers themselves are less willing to change the follow-up time, and parents are the ones that usually have this transition on their shoulders. At least we see this in our centers, where we still follow children that are even over 40 years of age. And here social workers, psychologists can help, and we were greatly helped by our psychologist for rare diseases, and she starts with children, but we have seen that the age of transition for adults is important as well, and this to help the patients and the parents of the child himself. And the case manager should be identified at a very early stage, and a doctor to take care of this should be identified as well. As Angela was saying, smart cards are very important when people go to the emergency ward and they find some things that are written and that are useful for the doctor, and we are called to talk to the emergency ward doctors. The questionnaires should be compiled by the families to receive suggestions in this sense, and this is a very important multi-center study where Barbara Pover is, and she's from Boston, and she's a supervisor there. There are 20 adults over 30 years of age that were followed at follow-up, taking into consideration heart problems, hypertension, and gastrointestinal symptoms, endocrine issues such as subclinical hypothyroidism. And these are issues that are very important. But another important issue is obesity that can happen. And as there is a proneness to develop type 2 diabetes, or so the glycemic intolerance, this should be taken into consideration and put ourselves and to carry out prevention. And this is Barbara Pober's work, and it's from 2007, but it's still very important for us to guide us in the aspects that should be highlighted in the adults. General aspects, nutrition aspect, and for example calcemia, that is not so relevant in pediatric age, probably also because nutritionists, people who follow the child, follow certain rules. So also achieving good motor capabilities. Cardiovascular problems are the ones we should take into greater consideration. For example, here we have a 22-year-old patient who had severe supravalvular aortic stenosis. She underwent surgery, but without a good resolution. She had a peripheral pulmonary stenosis that at 18 years old she had ventilatory restrictive syndrome that was severe, and severe pulmonary hypertension. She is being treated with this drug, phosphodiesterase type 5 inhibitor, for 3 years now, and she seems to be doing much better. That's because we oriented to a center for pulmonary hypertension, and but we remain the case managers. When should these checkups be carried out in adulthood? Every 3 to 5 years, and we have to find space for this. Annual auscultation of abdomen to screen for brood, for the evaluation of the abdominal aorta, and the violation of brood by Doppler. And also gastrointestinal disorder is functional abdominal pain. It's very frequent, and it shouldn't be underestimated, because on the one hand, gastroesophageal reflux issues are important, but also diverticulosis and diverticular disease shouldn't be neglected, especially in the adult. So the doctor should think about this. So chronic constipation is extremely frequent, so the supports that we provide for these forms with these macromolecules. Endocrine abnormalities. In adulthood, the issue of hypercalcemia can occur through nephrocalcinosis, so we continue to carry out renal ultrasound scans. We had this problem in some of our adults who are already over 30, obesity and subclinical hypothyroidism. With reference to subclinical hypothyroidism, Professor Di Giglio talked about it very well. So every 1 or 2 years, calcium should be measured in adults, and it should be compared with the normal findings for adults. Very often, these conditions can be recovered simply at the dietary level, trying to change the intake rate and also the actual calculation of vitamin D. When we have a DEXA scan and we have signs of osteopenia, we have to work, and so we don't start the calcium supplementation. We prefer physical exercise, and we assess vitamin D levels very well, and in severe cases we administer biphosphonates, but we should take into consideration gastroesophageal reflux and thyroid function. As we have seen, we have subclinical hypothyroidism that should be monitored, and Euthyrox treatment starts only when TSH is over 10. The other aspects, such as glucose intolerance and also peripheral insulin resistance, is something that should be monitored. Only 1C hemoglobin is not a sufficient parameter. I believe that it's worthwhile to carry out a load curve for glucose. Maybe something will come up in terms of insulin resistance and type 2 diabetes. Subclinical hypothyroidism it continues to be present, and it's connected with the small size of the thyroid. We don't need large doses of Euthyrox, genitourinary problems. We have already seen them, and in the adults we should also take into consideration bladder diverticula due to the deficit of the elastin gene. Other issues that shouldn't be neglected are the ophthalmologic ones, the audiologic one, especially the neurosensory auditory defect, especially after 30 years of age, and they should be considered as well. I would like to spend a few words on dental care. It's not that there is a predisposition to cavities, but there is a greater difficulty in taking care of dental hygiene, and so we have to work on this very often. And when we have dental care centers for children who have some difficulties, well, sometimes it takes suitable people to administer anxiety medication. And musculoskeletal issues, we have hypotonia in the children and lax joints, and over time we have a hyperreflexia and fixed contractures, joint contractures, and this lack of balance in gait leads to keeping knees always flexed, and this should lead to rehabilitation and a good physical therapy that should be dedicated is important. Neurological issues, I think that the afternoon session will be devoted to them. I just wanted to say that there are not any important structural abnormalities. Sometimes we have a type 1 Chiari malformation, but the MRI is not recommended. Cognitive impairment is going to be discussed today, and the techniques, because in adulthood, the anxiety issue that was underlined, so the colleagues will talk about it. One other aspect that should be considered, especially in young adults and adult females, should be the care to the desire to set up a family and to have children, and offer counseling in this sense, and to use contraception with a consult by the psychologist that can follow them up, but also a dedicated gynecologist that should be suitable to follow them. With reference to cancer risks, these are just reports of very isolated cases, and so at the moment we have no evidence of a greater predisposition. But the surveillance with monitoring that we have is that what we offer to these children: mammogram, prostate assessment, screening for colon cancer. All these have to be offered to them as for everybody. I would like to thank you, and I hope I was useful. Thank you.
Thank you, Professor, for this excellent review of the adults aspects of this condition. There are many guidelines that have focused on the differences of clinical phenotypes and on problems arising during adulthood. The problem in Italy is being followed closely, and to overcome this problem, because our people with the Williams syndrome age and have problems that must be taken into account, here we must adopt a bottom-up approach. In other words, pediatric centers did an extraordinary work over these years, but they should transfer these skills and these competences to major hospitals, to academic hospitals, to groups of experts of the adult. All these may play an important role. In this may be played an important role by the Association of Patients. However, these management should not be promoted by the Ministries of Health or healthcare system at the regional level. I think we should transfer all this information to the adult type. We are lagging behind our schedule, and we can make, however, a half-hour coffee break.
That we are with some delay, but there is no problem because one of the speakers